got to know. So I'm gonna push you over to Heidi. Thanks, Heidi.
Thank you, everyone. I'm very happy to be here with you. Just a little about myself. I'm originally from Guadalajara. I went to pharmacy school there. I worked like 3 years making medications, and my passion was more to be with patients. So I moved to the United States and start over everything. You can just transfer your credits from another country. So I went to pharmacy school. And when I was my journey, and for me, a little more my why I'm so passionate about diabetes. After pharmacy school, I had to do a rotation, so I went to a diabetes camp. Diabetes camp, and it was type 1 diabetic patients from 5 years of age to 18. I spent 1 week with them, and I was pretty much teaching them how to be independent, how to inject insulin, how to have the insulin pump. So I learned a lot. I didn't sleep a lot all this week, but after that, my passion for diabetes was like, it's just addicting. It's very complicated. It's bad at the same time. If you know what to do, you can make it happen. You can control the diabetes. You can even reverse diabetes. But it's very important that we educate our patients, because if you let it go, complications come, and then it's too late. And then you have a lot of problems, and a lot of people die with diabetes, because it's very important for you guys to know. So I just want to know, do you guys have an idea of what is diabetes? A little bit? Yeah? There, okay. We're gonna go see. Have you guys been, in clinic for diabetes in the last? No?
She's speaking. I mean,
Yeah, okay, good. It's very important. I'm gonna go to and start because. So first of all, diabetes, the name is diabetes mellitus. Mellitus. And it's diabetes is a Greek word. It's to pass through. Mellitus is sweet of honey. So this was because in 1650s, and that time, they already exist diabetes. And they were figuring out that people with diabetes have the urine was very sweet, and that's how they are like pass you through the sugar. So our body is supposed not to reabsorb everything. It goes back to the body, so we don't supposed to have sugar in our urine. But with our body have a lot of more sugar, what it's gonna do is gonna try to excrete all the sugar or with glucose, we call it glucose, through the urine. And that's how they detect diabetes in 1550. But diabetes is a chronic disease where the amount of glucose in the blood is higher than normal range, and we're gonna go through which one is the normal rate. And we need the glucose comes from our diet, and carbohydrates and starch and sugar coming from our diet. It goes so, and this is a very good example. So in order for us to use the glucose as an energy in our cells, we need insulin. So insulin is the little key that I have there. So if you have insulin, the insulin open the door for the glucose to go inside of the cell. So you can use the glucose as an energy. Okay? So what happens is, if we don't have enough insulin, a lot of glucose go outside. Another problem is if we have insulin, like the insulin goes in there, but it's not a good signal between the insulin receptor to the glucose channel, the glucose cannot go in there. So that's called insulin resistance. Okay? And we're gonna go through, if you don't have insulin, that can cause the same problem. So this is a main thing to understand, because that's how blood glucose elevate in your body. So if we eat a lot of food that has sugar and we don't have enough insulin, that's what's gonna happen. Your blood glucose is gonna increase a lot. So the symptoms, if you ever have any of these symptoms, so know people that have diabetes, they are always going to the restroom all the time, like excessive urination. Why? Because your body's trying to excrete the glucose. Polydipsia means that you are thirsty all the time, and it's because you are dehydrated. You're going to the restroom and you're excreting the glucose, but you know your water because you're always thirsty. Weight loss, and people have blurry vision, infections, because you are having glucose in the urine, bacteria grow in the urine. So it's a lot of UTIs. So a lot of people have constantly UTIs because the glucose in there. And then Pinbody allows filling of the cans of feed. So when the glucose is excessive in the blood, it goes through different arteries, and the small ones, remember, in the feet and the hands, they clot them. So the circulation to the blood to all the cells and there is not good enough. So when that happens, you have the tingling and the burning sensation. So people start feeling the feet and the hands, and they have this burning sensation. People with diabetes probably can tell you. Right?
I need to go urinate.
Visual aid.
That's
He's
part
gonna
of
talk
his
about his journey with diabetes.
Yeah, so that's part of
Right now.
his presentation.
Any questions right now? Okay. Okay, so what is your normal range of glucose? So we, when ask you if you guys screen it, because when you go to the doctor and they ask you to have blood, like labs, and you have to be fasting, means 8 hours of no food or drinking sweet sugar. You guys remember that you have to go and like, so they check your fasting glucose. It's okay. So your normal level is gonna be less than 100. And if you have pre-diabetes, it's gonna be between 100 and 125. And if it's more than 126, it's considered diabetes, okay? It's another test that is called OGTT test, and this is a test they use for patients since they are pregnant. So they give you a liquid that has 75 grams of sugar. And 2 hours later, they measure your blood to measure how your body actually excretes the glucose in from that drink. So they check your sugar, and that should be less than 140. But if it's between 140 and 199, it's pre-diabetes, and if it's more than 200, it's diabetes. Okay, the other test that we use is A1C. I don't know if you guys remember here about this test. Okay, this test is the average of glucose in 3 months. So what happens is the glucose after being in the blood, they bind to the hemoglobin and the red blood cells. So they bind it, and so this test measures the amount of glucose and the hemoglobin. And because the red blood cells are, their life is only 3 months, so they can see all the time all the average of your glucose on the night, on the morning for 3 months. And this is a percent. So it's very actually good to have this percent, just because a lot of people say, I measured my blood glucose in the morning, it was fine, but that doesn't mean that it's always fine. You know, at 9 or after eat can be very high. So after you have 2 tests, they are higher than the normal, they can consider you if you have diabetes or pre-diabetes. Okay, so if when you go to the doctor, he's hopefully checking to be sure that you guys have normal levels of this. Or if you are pre-diabetic, the public doctor cannot tell you that you need to start with probably diet and exercise. But we go through the types of diabetes. 3 types of diabetes. Type 1. And normally this is an autoimmune disease. So normally this happens in kids and children. So the body thinks the beta cells and the pancreas, is supposed to be like a virus or something. So our own body attacks the pancreas with beta cells and destroy them. And these beta cells are the ones that produce insulin. So when this happens, the people start getting super high levels of glucose, and the pancreas cannot produce insulin, so they go normally to the ER very fast because the levels they make them super sick. They start vomiting, and it's just like something that happens super fast. These people, these patients with type 1, they have to be on insulin for the rest of their life. That's it. It's for them, it's not cure. It's just they have to use the injections with insulin, or they have to have the insulin pump. But normally it happens for patients younger, but it happens for patients older too. This can happen anytime. Type two diabetic is patients experience high blood glucose, but mainly because they have insulin resistance or they are overweight, obese. So the fat actually make the insulin not work correctly. So that's when that happens, the insulin can't even bind and the little key cannot go into the door, so the glucose cannot go inside. Extra fat causes that, so we want to be sure that's why it's good to have a good diet and exercise, just to be sure that excessive of fat is not making you, high blood glucose. And the other one is gestational diabetes. Gestational diabetes happen only during pregnancy, and normally the levels is more like a pre-diabetic, but we want to be sure that the pregnant women, they don't have a high levels of glucose because the babies can grow more weight than normal, and they can have like stress when they have the baby. And these kids are actually in risk for to have diabetes too, and the moms too. So that's, this is the levels for fasting and for A1C, and they use the other test that I explained you before, the GTT test, where they drink the 75 grams. Risk factors. I think I passed you through this little page, just if you guys know if you have risk factors. If you have more than 5 in this, it's considered you are in risk for diabetes type 2. So age is one of so screening should be no later than 35 years of age. So your doctor should be screening very often, at least once a year. And if your patients, if they are for young people, if they're obese or overweight, they should screening too, just to be sure they don't have diabetes. Patients with conditions with insulin resistance, we talk about it, fathers cannot make insulin not work correctly, so like obesity and even HIV can cause that too, like I will explain in a minute, but family history, your mom, your dad had diabetes, you are in a high risk to have diabetes, and if your brothers do. So that's something else, gestational diabetes. So if your mom had diabetes when you were in the pregnant, so you have a high risk. If the person that has gestational diabetes has a high risk too. For race is actually very important too. We Latino, African American, we have a high risk of having diabetes. And another thing, physical inactivity. If we don't exercise, it's gonna be a high risk for us to have diabetes. Well, diabetes and HIV, I wanted to be sure, you understand it's a little, we have more high risk if we have HIV because when the virus come in the body, it's like a inflammation, activates a lot of cells for immunity, and these cells of immunity make the insulin to not work correctly. And at the same time, too, the pancreas doesn't produce a lot of insulin. So this happen only when you have HIV, but you don't take medication. That it's like, right now, their replication for the virus is a lot. So when we have suppress our virus, this is not something that you have to worry about, okay? So taking HIV medications can actually, like protease inhibitors, ritonavir, darunavir, this is a class of HIV medications that can cause insulin resistance. So insulin doesn't work the same way like normal with this medication. So that can make you at risk for to have diabetes. So we just want to be sure, if you are in a protease inhibitor, your doctor check you more often to be sure the blood glucose is not high.
So if you took one of those years ago, but switched, is there a recovery from it?
No, it just happened while you're taking the medication, so
Or
you're,
taking it?
yes. So, but at the time that you were taking it, I'm sure your doctor was checking to be sure your blood glucose were not increasing. But it's no problem if you don't take it anymore, it's just during the time, yes.
That retinol that's basically an example, it's not that, for there are lots of drugs in the protease,
Yes, it's just an example because a lot of people know ritonavir.
yeah, 'cause I've been on one for 20 years.
Yes, darunavir is another one, it's just it's a class, it's just I put the one that almost everybody will know. but it's just a class,
Does the whole class end with beer?
yes,
All-
not beer.
Right, okay.
Yeah, so we wanted to be sure, that if that's the only regimen that you can take, it's fine. But we wanted to be sure your doctor is checking your blood glucose frequently, okay? Another thing is that hepatitis C, a lot of people with HIV that has hepatitis C too, like it's co-infected. Hepatitis C, it's a virus that damage your liver, and your liver is very important for diabetes because the liver is the one that stores your glucose. And actually, when you have hypoglycemia, when your blood glucose decrease, your liver produce glucose fast and send it to the body, okay? So when we have hepatitis C, it's gonna damage our liver. So this process is gonna affect you. So it's important if you have hepatitis C, you try to take your medication to cure because now you can be cured for hepatitis C. So your doctor, I'm sure, is checking all the time to be sure that you don't have hepatitis C. And having lipodystrophy. This, it's a change on the body fat. This, you can gain or lose fat in different part of the body. That was very common in the beginning of, HIV when we were using medications like sakinavir, sidovudine. They were increased more the fat in different part of the body. But now you don't see it too much. So with the new medications, you guys don't have to worry about it. Okay, so let's go to the next one. Stop sharing. Lifetime modification. So let's see, you go to the doctor, they check you and they say you are pre-diabetic. The first thing that they're gonna ask you is to do lifetime modifications. And that's something that you guys, if you already have a high answer in your questionnaire more than 5, you should try to do something like this because you want to avoid to have pre-diabetes and diabetes. So main thing with diet is we want to be sure we don't give a lot of sugar to our body. Okay, so we're gonna try to have more Mediterranean style, so more vegetables, more greens, less fat, less like starch, and less like carbohydrates. The carbohydrates would be like in the pizza, all the wheat, The starchy vegetables would be like potatoes, corn. So we want to do more green, and you can eat it. It's just the amount of vegetables that with the starch, because starchy vegetables should be not too much. Just try to minimize the carbohydrates in your diet. You still can eat it, but healthy carbohydrates is better. So we have healthy carbohydrates and like vegetables but no and wheat, like in tortillas, like wheat tortillas. So bread. That's something that you can have it, but try to minimize it. And another thing is in moderate intensity physical activity. So they recommend to do an average of 150 minutes per week. That would be like 5 times 30 minutes. 30 minutes, 5 times a week. So it's, if you can do that would be great. It has to be moderate to intensity, so your heart rate have to increase a little more than normal. So try, if it's a walk, it's a fast walk, it's gonna just, and this is gonna help to improve insulin sensitivity and reduce the fat, and that's what we want, okay? So when you go to the doctor and say you have pre-diabetes, this is where you're start. If this doesn't work and you come back to the doctor and you're still pre-diabetic, your blood glucose is still high enough, they're gonna start you on medication. The first medication oral medication that we use in diabetes is metformin. Everybody heard about metformin, yeah, I'm sure. Metformin is a great medication because it reduces cardiovascular death and events and death. So it's the only medication in diabetes. So a lot of doctors always push to the patients use it, but it has a lot of side effects. I don't know if you've been using it or hear about it, but normally in the beginning you have to start it slow, and it's gonna cause a lot of diarrhea, nausea. So that's why you start with 500 milligrams once a day for like 2 weeks or a month, then increases slow, okay? So that's the main thing, but and it's extended release metformin in case that this is still very bad for your body. Drug interactions with HIV medication, Dr. Caperna wanted me to be sure I talk about this. So there is the new medication now on the market that has INSTI. It's like second generation of INSTI. That would be bictegravir or dolutegravir. They both and the new medications now in the market, and Victardi, Dovar, all that. It's okay to take metformin, but if you are in Victardi or Dovar and you need to start metformin, you need to start slow because they compete for the excretion in the body. So metformin increase a lot in the body when you are taking these HIV medications, okay? So if you need to start metformin, you need to start slower than other people. So 500 milligrams once a day and see how you feel. If you have side effects, you can do half of the tablet, and from there it's increase just slowly, just to be sure you don't get a lot of side effects. Okay, it's good thing to know. Another thing is when you take metformin for years and years and years, it's gonna decrease your vitamin B12, and so it's constantly good to check to be sure your levels are normal, because if you are low in vitamin B12, you're gonna have more neuropathic pain. Okay, so that's another thing good to know. Maybe, you can take vitamin B12 and you're diabetic, would be great to help you with that neuropathic pain. Okay, after metformin, if that doesn't work and you still have high blood glucose, they do use other medications. This one's now because if your kidneys are in problem and risk, you cannot use some of the sulfonylurea. It was actually glipizide was used a lot before, but it causes a lot of hypoglycemia, so it means your blood glucose goes drop very fast. People start like failing, and so doctors normally use metformin and then maybe one of this, but now they go to the injectables. The injectables, they are very, and I think everybody hear about the GLP-1s. It's almost on the commercials and everybody. This medication, it was start actually for diabetes. Now it's used a lot for weight loss too. There is an enzyme. We have the GLP-1 enzyme in our body, but when diabetes is decreased, and when we put an extra GLP-1, it helps the digestion decreases, it slows the digestion, so people actually eat less because they feel full very fast. Okay, and then helps with formation of glucose to decrease the formation of glucose. So it helps in a lot of ways the diabetes, but on the same time it makes you lose weight, so that helps the diabetes too, because it increase your fat. So the first medication started with Victoza. Nobody really used it too much because it was an injection twice a day. So people didn't want to do injections, but then it got better and they started using Trulicity as once a week. And from there is Ozempic and Mounjaro. They have different brands for weight loss for the same active ingredient. Just be sure if you want or hear people taking this medication, they have to eat healthy. They still have to eat a lot of protein. And they can have hypoglycemia, so they can increase the blood glucose where they can pass out if they don't eat enough. So that's good, it's once a week, and it's just a great option for diabetic patients and for weight loss too. And the other one would be insulin. Like I talk about it, type 1 diabetic patients, they have to have insulin. So we have different kinds of insulins, long-acting, short-acting. Normally patients start on long-acting once a day, sometimes twice a day. It's a lot of the medication they have to inject a lot of units. So this is an example of the long-acting, is Lantus, Basaglar, Levemir. And then the short-acting is if after using the long-acting is still not controlled, so they can use the short-acting just before meals, like a small units, 5 units before breakfast or lunch. And that's can be twice a day, 3 times a day. So you just have to, according with your blood glucose levels, you have to check what is, your doctor will tell you what would be the best option for. Before used to be Humulin, and this is like NPH is called, it's just twice a day. Okay. Okay, glucose monitoring. So the picture on the bottom is what you normally see the people does, it's just, you have to poke your finger, you have to get your little drop of blood, and they can measure the amount of glucose. They recommend on once a day, twice a day, different times. But a lot of people there's like, I don't want to do the poking all the time, yeah. And I get it, it can be painful for after doing it for like twice a day for like months and months. There is new options. The glucose finger monitor now, you can even, that have a light, they actually censor the glucose molecule, so it will tell you average of quantity of glucose. But I'm gonna say it's less sensitive, so this is actually better. You can always use that, but if you see something very, I don't think it's right, you have to have your extra option. And this is actually the newest thing that everybody's talk about it, is the glucose monitor, continuous glucose monitor. So we have two options, it's called Freestyle and Dexcom. So like you see right there, it's like a sensor, so it goes in your arm or in your stomach, on your leg, and so with that application, you just put it on, it goes inside of your bloodstream. It's actually detecting the blood glucose all the time, like every 5 minutes it changes, and it passes the sensor to, and you can use your cell phone, or you can use the little, it's kind of like a reader. It's like a cell phone, but if you don't have a smartphone, you can use that reader that comes with, okay? So Dexcom, you have to change the sensor every 10 days, and Freestyle is every 2 weeks, okay? And this is something that insurance will pay for if you try already the old fashioned, and if you have insulin or you have complications, it depends on your insurance. Normally, they will pay for the Dexcom or the Freestyle. Okay? And complication, there's a lot of complication for diabetes. So we want to be sure before we go through any of these complications, you guys start doing like diet and exercise, medication, and try to, if you lose the weight, if you exercise, you can reverse the diabetes. You can be again like have normal blood glucose levels. So this, if you let it go and you continue not taking the medication and you don't care about it too much, or it's just very difficult to control, the complications can happen. So because the glucose molecule is big, they're gonna go to your eyes, block their little arteries, and they can cause glaucoma, or they can cause cataract. Or they can go to the peripheral artery disease, so you have problems with clots. You can have complications with peripheral neuropathy, so pain in your legs and your arms, and it's like the tingling sensation. Your kidneys are they are filter your blood every day, and if you have a lot of blood glucose, they're gonna damage the kidneys. So you're gonna, people with diabetes can have they go to dialysis. So we want to be sure to avoid that. And diabetic food is when they don't feel the food, and so when they step in things, they can get cuts and they don't realize. So they have infections and they have to have amputation. So all these complications can happen if we don't control the diabetes. So we wanted to be sure, you guys have a little information of everything, but you have any questions, I'm here to answer. Questions? Yes.
Okay, one of the problems is that these things confuse me. For instance, I've been on protease inhibitor since the beginning, which is more than 20 years. I've been pre-diabetic for more than 20 years. I have cataracts, and all those things. And yet I'm not on any medication for it.
Are you pre-diabetic?
The doctor says I'm pre-diabetic, but I've been there for 20 years.
Okay, so some doctors have different approaches. So some want just to watch it, just be sure you don't go to diabetes. If you've been doing this for a while, they're probably just seeing, okay, he's not going.
They tell me it permanently.
Diet and exercise, yes.
Well, I don't think, but no,
Well,
I like this.
Okay,
And
so like I say, small changes in the diet will help your blood glucose. You don't have to change everything, but if you do small changes like Pepsi, if you can fix
And the diet stuff doesn't work.
stuff as well.
His is wrong.
So what about you try like water?
You your own worst enemy.
Something different, maybe try a different.
I've been drinking it for 50 years.
Okay, so it's not gonna work. Well, you can always, ask if you can have metformin. Metformin, well,
No, like I said,
they never say anything about it.
they tell me that basically this, change my diet. They keep telling me to change my diet.
Well, just tell them that you try it, it doesn't work.
Oh,
So now,
No.
what is next?
I like that.
Exactly, because you're not gonna take
And I
that.
don't like this diet.
So maybe the metformin in a small dose will help you.
Oh, no, they haven't actually told me I needed to because that
Oh.
day, but it goes back and forth.
Oh, okay.
Before my blood work, I will cut down a little bit.
So you tried this metformin?
No,
Oh,
I tried cutting down on this.
oh, okay.
Immediately before a test, so you test well.
No, I do.
Okay, oh, okay.
You can ask doctor if they want to try metformin just to be sure you're.
Well, no, why would I ask for another medication if they haven't decided I need it?
If you're worried about it.
I'm not worried about it.
Oh,
They're the ones
okay.
that-
If you're worried about it, well, can you try to, if you can try to change your brain, what about your diet? Can you try to change your diet?
Oh. I have no gallbladder now.
Oh,
I haven't get kidney trouble. It's a guess, but
okay,
overall, my labs will go back and forth.
back and forth,
But a lot of it's genetic,
yes.
high cholesterol, but, excuse me, but very high HDL.
Yeah. Well, another thing I was gonna say, American Diabetes Association, if you go to the website, they have a lot of like recipes, healthy recipes for you guys. So you can print or you can just look at your phone and make recipes and that will help you to have better choices if you guys want to do that. It's
I have a question. So the PCI is one of the medications that is associated with,
Yeah.
conditions that need to be better, but can he ask to optimize his treatment? Can you have take that to your?
It's really the old protease inhibitors. The newer ones, I don't think there's data. Like if somebody's on Frizista, Simtuza, those are okay. Right, but the old Trixavan and
Tinavir.
Fortivase and, right, Inverase, Sequinavir, those are really bad.
Well, they, I don't know, like your regimen is because you cannot take something else.
I've only lost the, first class, not loose to everybody, the verification class, that's gone, but other than that, everybody.
Okay, well, you can always ask your doctor to fix a better regimen for you too,
Well, I'm thinking, no, I'm totally stable, I'm just saying, all these things, but like I have, when you talk about the dropping of the thing, I actually do have a syncopia, so I have to sit there and be careful about changing, elevation, cause I do get dizzy, or, I do change the system that hill. But, they never said they told medication, except, like, you tell me about my diet, that's the one thing you've been telling me about.
Well, it's the main thing, whatever you bring to your body, is glucose coming in. So the main thing is your diet, but if you can switch your, that is another option. That's your doctor.
Right, so I just want to say, I used to drink 2 to 4 liters of Pepsi a day, up until about a year ago. And I substituted with sucralose, and I find that works.
It tastes better than the other stuff, but no, I put it out in my car.
So you mentioned the website, American Diabetes Association. That is ADA.
ADA. It's great, has a lot of information for patients, recipes, even exercise, it's just like a lot
It's
of,
called Cooking Well, they have a whole program,
yes.
Cooking Well.
Yeah, and even your insurance too can maybe cover you to go to a dietitian that could help you to give you a little more information, like for you specific drugs that are, correct. That's another option.
Another good resource is Aging and Parent Services. They have an overadult nutrition program that specifically deals with diabetes. But I wanted to ask about the You mentioned all the different complications. I didn't see edema on there, and I see edema quite a bit for a lot of folks who have the vascular issues associated with diabetes. And that's a lot of the swelling.
Yeah, the edema can be for the heart, having congestive heart failure. The edema can happen, so you're affecting your heart, you're affecting your arteries, so it can, and there is two medications that can cause edema that they use in diabetes too.
Really?
Yes, like
Medication.
pioglitazone, yes, like, so that's why, you can see edema too, but, and the kidneys too, if the kidneys are damaged, those, they of course are not gonna filter the blood the same way, and it's gonna have edema, so it's just part of, all the complications.
More of a symptom of.
Symptom,
the
yeah.
diabetes. Okay.
Yeah, just like you said, it's a part of the vascular.
Part of the vascular,
Just like you said, yeah.
So
Neuropathy,
recently I've been given a heart medication called Jardiance.
Mhm.
And since I've been on it, when I get a blood test, my doctor, my glucose has been skyrocketing, but my doctor doesn't even look at it because he says it's an effect of the Jardiance.
And the urine.
Okay.
Yes, normally you don't supposed to have glucose in your urine. When you use Jardiance, how medication works is actually make your body to excrete more glucose.
Okay,
So when you go to the labs, and Jardiance can be used for something else, like congestion, for like heart problems.
heart and diabetes,
In
right?
diabetes,
It's both.
yeah, both.
That's both.
So when you go to the lab, you have to tell them that you take that medication, because if not, they get scared, like it's a lot
Right,
glucose in.
right. I get scared.
Yes, you get scared, and they probably tell the doctor this is, but normally it's part of the medication, because that's how it works.
but you also learn how to dance the dance, the Jardiance dance.
Oh, yes, yes. Every day.
So it's normal to have glucose in the urine when you take that medication, or that class of medication.
What I'm concerned about is if I am pre-diabetic or something like that, is this going to mask tests for diabetes?
No, in the blood, because normally they check your blood, not
Okay.
your urine,
Okay.
or like diabetes.
Okay, all right.
So
The
it's
urine
like
screening
enough.
is not gonna be
The
helpful.
screening is, yeah,
Okay.
And other screening tools. That's
yes.
My real question was, if you've been under the same doctor's care for years and you know about all these things, should you really be worried about these things, or basically just, I'm listening to my doctor and they sit there and say, I don't need all the extra stuff, so I'm not really all that concerned, even though if I go to the lectures like these and I see all these things, and I got all the warning thing, but my doctor hasn't expressed any major concern except for the fact that they do want me to change my diet. Should I?
Well,
How do you feel with your doctor? I'm sorry, how do you feel, how confident do you feel in your doctor?
Oh, now, like I said, it's been a long time. In the very beginning, I had lots of, I questioned her a lot. Because the doctor before her didn't catch the fact that he had me on too many medications that almost killed me. They told me I was in kidney failure.
So I definitely,
But the new doctor had basically, over the years, he actually knows me and I feel comfortable with her, so I question, or except for the fact she does constantly complain about my diet. But it's been over 20, almost 20 years, so do you really worry about things like that?
so I will.
Knowing that you should change your diet, I mean, I'm 75, so I should change my diet.
I will just talk to your doctor. If you really like your doctor, you don't want to have a second opinion with a different doctor. I would just talk to your doctor and tell them your concern and you cannot change your diet.
Well,
But
no,
it's next,
no, not, I don't have any concerns. She knows I'm not going to because she's also referred me to, a dietitian many times, and I said, I'm not gonna do it. I mean, I go to the dietitian, but I cannot follow their recommendations, so, but, and since things are not getting worse, should I really, I would think that.
Worry if I was you. I'm just saying, like, because
I want to.
yeah, because you're 75, yeah, even if you don't have no problems since you say you have it for a while, but that can happen anytime, and you can have like a heart attack or stroke. Just,
Increases your risk for many other.
Well, I
things.
understand that.
Yeah.
My sister has stents, my brother was diabetes, they have all these problems and.
Even with that, you have even more risk because just the history of your close relatives.
And
I think
HIV
that's
is
what
like
important.
2 to 10, correct?
Exactly, I think that's where it's important of having that conversation and being your own advocate with with providers, right? When you provider and say, "No, we don't have to be concerned, but I have to recognize a patient, I'm not gonna be able to make the change that your suggestion, so one of the options that I have.
Yeah.
Because, some providers are like, well, the patient wants to kill themselves, the patient wants to kill themselves.
Well, not necessarily.
No, but like,
Can't
they
make-
can, yeah, they can make you change, and
It's
you
our
are,
option.
yeah, and you are not worried about it, so.
Well, no, I was worried about it, cause trying to follow their changes, I found other problems, for instance, I cannot physically eat the types of foods that I eat, this is a lot of food for me, but I really eat low caloric foods. I got a gallbladder, I'm not supposed to eat fatty food, but I couldn't maintain the hospital, usually they try to do that. And I just can't do, and they try to support all this thing, so they found we had to give me medications to, replace some of the fat that just.
Yes.
Because it just does not, the diet and things does not work. I mean, I physically can't eat that. Yes. I don't get hungry.
Why it would be good for you to start a medication for diabetes.
Or at least have the conversation. I think the big.
Okay, is it ready now?
Yep.
Okay.
You know, there's problems, but. if
But they
it's-
know that, my home here, they know that, and they never even suggest it.
I think the biggest thing, and correct me if I'm wrong, is to have that conversation. Dr. Furnace says, having HIV makes it times two. Having two diseases that are both inflammatory diseases
Yes.
really can create havoc in your system. So that's why to be aware of this risk. You don't want to add another inflammatory disease on top of one that you're already living.
That's the time.
Well, thank you so much.
you. Okay. Yes.
Okay, so, we're gonna,
Wanna switch a little, this is tight for time.
yeah, okay, so we're gonna bring the drug in?
Yeah.
Okay, I'm sorry.
Do you need to
What's-
log into
yeah.
the
Yeah,
website?
just-
I do. Well, I don't need to log in the Wi-Fi. I just need like a HDMI or
Yep, we have an
something
HDMI
to
cord right here.
connect to your projector, basically.
Yep, we have it right.
So his name on it. Mr. Vita from-
But if you do want to log into the Wi-Fi, I have the code here. Just leave, yes.
Okay, no, I just
You're good.
need to connect. my computer.
Right here, you've got it.
I'm gonna move that over there.
Here, you
These
can.
guys are doing their transition.
John up here.
I think it's gonna be quick. How are you? You have everything? Don't forget.
If anybody wants more food or drink, there's healthy yogurt, juices.
And you hang for a couple hours, John.
Thank you very much for
Yeah.
Thank you. Always appreciate having you guys here. And next month, Dr. George is gonna be here for the April, the first Saturday of April.
Thank you.
Thank you very much.
Yeah.
So as we transition. Oh, there we go. Thank you. Love you.
Maybe you pointed at the computer?
Yeah,
Yeah, because that's just gonna reflect what you're doing on your laptop.
it's
I don't think
working.
any- Oh, you're trying to use a pointer.
Yeah,
Doesn't show up. That's very bizarre.
it's alright. I can just use the space bar.
Jason, give a big stick. So we can point. The little red
No,
pointer.
it's alright. I'll just use the space bar.
I can be your Vanna if you need.
You are way hotter.
Or that doesn't work, then it does.
I can go to Vanna.
You sure? Alright. We're gonna go. without. Anyways, so can I start? or-
Yes, please.
Yes, you're
Please
for
just
time.
say your name.
Yeah,
again.
my name is Truck Shop, I'm Farm D by background, I have been what we call a medical science liaison for about 20 years, and so I explore both medical questions as well as our research anywhere from phase 2 to phase 4 trials that we do throughout the US. I'm based here in San Diego, so I cover Southern California. And I do have the privilege of covering Hawaii, so I have to go to Hawaii sometimes. Yeah, making you all jealous, yes. Next month I gotta go to Honolulu for 5 days. I know.
Do you need an assistant?
Yeah. I can always use some additional help. But basically, Dr. Caperna reached out to us through our call center and said that, you know, we have a new medication that just got approved on January 30th. The generic name is Suzetrigine, as you can see on this slide. The brand name is Journavx. And through our communication with Dr. Caperna, I let him know that the current indication right now is acute pain, so moderate to severe acute pain. And we had a conversation and I said, look, I realize that this is mainly the HIV type of conversation. So this would be technically what we consider off-label usage. We do have some neuropathic trials that we're conducting right now, and so I can show you some of that data as well. But largely, this is, I have to go and preface this from a legal standpoint that it is for acute pain. You can use this for acute pain if you guys have a patient population that is suffering from acute pain, and that's completely unlabeled, but the neuropathic pain currently is being studied, and so that would be considered off-label. The way that I give these talks, I'm not one of those like, oh, hold all your questions to the end. I like to hear the questions as I'm presenting because personally I feel if I'm in the audience, it's fresh in my head and I want to ask that question. So please feel free to just raise your hand and stop me because I don't want you to lose that question. Go ahead.
Okay, so for example, my name's Dr. Caperna. I have a patient that takes intermittent Norco for his peripheral sensory neuropathy and for really kind of bad arthritis hip pain. It only takes like maybe a few a month, like maybe 3 days in a row.
Yeah.
Would this fit?
So you're gonna see in our
Is
clinical
neuropathic
trials,
and-
we actually did go head to head with Norco, looking in acute pain. So I will show you that data over here. I mean, obviously that's up to you as a practitioner. I can't give you medical advice as far as whether it's gonna work or not. You can try it, it's on label. And we do have a comparative data set because in our clinical trials, we had 3 arms. So we had our arm, Suzetrigine, we had a Norco arm, and then we had a placebo arm. And so you're gonna see real head-to-head data within the clinical trial setting. I always preface, clinical trials don't always correlate to clinical practice. So that's, are trials that the FDA goes and mandates. And so you have a cleaner patient population, not a lot of comorbidities. Is it gonna translate over? That's up to the patient and up to you. Yeah, go ahead.
So there's another patient who's very informed, who said, well, Paxlovid interact really strongly with my HIV meds, but they said, I can take it for 5 days, doesn't matter. So would that also apply? The P450 wouldn't get, the interaction wouldn't be so severe?
Yeah,
3
so
to 5 days later wouldn't bump the levels up too high?
So there are, so this is, and you'll see this through my presentation, but I'm happy to answer the question right now. It is primarily metabolized through the CYP450 system. So in particular, the CYP3A substrate that the liver uses. And so this can cause a difference in levels in strong inhibitors or strong inducers of CYP3A. And so all you have to do is, it's not a contraindication, but it's something that you have to go and monitor the levels to go and say, and we haven't tested every single CYP3A inhibitor inducer, right? So it's something that as a practitioner, Yeah,
That
so.
intuitively seems okay, but I need some data.
Yeah, so I mean, the only data that we have is in child Pu C patients, definitely avoid it. Child Pu B, so they have some kind of liver failure. You could dose them normally for the first 5 doses, which is technically 2 days. And then after that, you go from a BID dose to a QD dose, just to make
Oh,
sure,
Right,
yeah.
so maybe if there's a strong interaction, we would just guess and just only give it once a day to be safe.
I mean,
That's what I'm thinking right now.
yeah, in the era of caution, I would say probably QD. But we haven't studied it that way, but I mean, I would start, if you have somebody who has some real hepatic issues, I would probably start QD and then see if it's efficacious or not, and then move in to BID otherwise.
And do other drugs affect Suzetrigine's levels?
Suzetrigine's levels.
Right, is it a substrate for other drugs or just an inducer?
It
or
is
inhibitor, I mean?
both a substrate and an inducer.
Inhibitor.
So, I'm sorry?
Inhibitor, it inhibits, so it leads to higher levels of the HIV.
It could lead to higher levels of other medications that go through the CYP3A
Right, okay.
system. Because they're basically competing for it.
Yeah.
So that is something that you definitely have to keep in mind. Go ahead.
I just was gonna ask if you can make sure folks understand the difference between, or the definition of acute versus chronic, so that there's a clear understanding.
Oh, yeah.
Sure, so acute pain, just per the CDC guidelines or any kind of government. Which is 3 months in diabetic peripheral neuropathy, which is probably what I would consider most of your HIV patients that you're treating have more neuropathic pain than acute pain, and that's why I'm trying to tailor this a little bit more to you. But less than 3 months is considered acute pain, more than 3 months is considered chronic pain. Fair?
Yeah. so
Any
I
more
think
questions?
you're-
Yeah, no, and stop me anytime, so. Okay, so now this goes on. What is going on here?
Shouldn't be the HMI, but I can take it out, right?
Yeah, let's see what's going on. How did that just freeze up? Alright, plug it back in, let's see. We got a lot of technology sometimes, right? I apologize for this. You okay?
Okay, back up.
That's gonna be so smaller. If you guys wanna pummel me with questions in the meantime, go ahead.
I have those.
No, I have full batteries, so, and I have my power cord with me, so. I need
There's an extension.
Is there a maximum number of days it's approved to use consecutively? And
So,
can you use it with intermittent breaks and then start again?
yeah, so the maximum dosage per our label is 14 days. Obviously, anything past 14 days, we consider off label. But we have studied it up to 14 days for, oh my God.
I know there was like hernia, bunion surgery, I
Something's
can't
happening.
remember what else I read.
Well, it's not hernia, so the two
Post-op
major,
something.
the two major surgeries that we did to go and get FDA approval is abdominoplasty
Oh, that-
and bunionectomy.
okay.
Yeah, so we have not studied it in hernia patients.
And then can you take a break after 14 days, like take a 14-day break and start again, or there's no guideline about that, about repeating within a year?
Yeah, I mean, that would be up to you, right? So, we haven't studied it with, 14 days of exposure, taking a break, then you can take it 14 days again. We have not studied that, so I have no guidance to go and give you on that. I can tell you that we have studied in a phase 2 trial, so not indicated as of yet, in Japan, that they continuously took it for 3 months.
I saw that, it looked like it. Against placebo, it wasn't better, okay. That was what I
That's,
saw.
you're probably talking about our lumbosacral.
Some kind of subset, I'm not remembering, right, anyway, go ahead, sorry, yeah.
Yeah, so there's 2 neuropathic pain trials that we did. We did one in diabetic peripheral neuropathy, and it was head-to-head with Lyrica. Lyrica did separate from placebo from baseline, but all of our 3 doses that we tested did beat Lyrica TID, and this is a QD dosing that you have. Lumbosacral radiculopathy, we just released our results in December, and we had a consistent effect. So when you see the pain scores, it dropped by 2.02 on the PRS scale. Great for placebo. Placebo got a 1.98 in our trial, and so we didn't show any kind of separation because of that. And so we are still pushing forward with our phase 3 program for lumbosacral radiculopathy, but I be honest, our phase 2 did not separate, and it wasn't in our minds. It wasn't because the drug didn't do what we expected to do. It just placebo knocked that out of the park. And you know, placebo is it's a great drug in my mind. I mean, as a pharmacist, I've done so much research on placebo effect, and sometimes placebo is just great.
Can I ask you a question? The dosing you're talking about, the QD and the BID and the TID?
QD was once a day,
Okay,
BID
Oh, I'm
was twice a
sorry.
day, he said BID was twice a day,
okay,
Yeah.
QD is once a day. The
okay.
QID, he said, is 4 times a day, one of them.
No, I
Or
did
3
not
times
say
a day,
QI.
yeah, 3 times, you said 3 times a day for America, right?
For Lyrica's approved
Yeah.
dosing is the TID 3 times a day.
Okay.
I
I was trying to buy you some time there.
appreciate it, thank you.
Perfect.
This coming up.
Audience,
Oh, all right, well, we're having a look here. All right, slide decks back up.
Yay!
All I had to do was restart it. Okay, let me get into it, and I already spent 10 minutes of your time, so I'll try to cruise through this. But once again, please feel free to stop me at any time, and we can have this interactive conversation. So, as I was mentioning, our phase 3 randomized control trials that we did were in abdominoplasty as well as bunionectomy. And for the FDA, you have to, if you want to get an indication in pain, you have to do one what they call soft tissue, so abdominoplasty, and you have to do one what they call bony model, which is bunionectomy, and some other companies. So you have the option of choosing bunionectomy, or you could do a dental model. We chose to go and do bunionectomy. So other companies have done in the past, and they're more than fine to do it right now in a dental model. So, and then we did an open phase 3, and probably the last one is the most relevant for your patient population with neuropathy, so neuropathic pain essentially, right? Because back in pharmacy school, I used to treat HIV patients, and obviously they were having neuropathic pain and not so much acute pain necessarily. So we'll talk about that. So I'll fly through. I think the mechanism is something that is very important. It's a very novel mechanism. So this is the only one drug that's approved in this mechanism. So basically, what I like, let me just ask you a question. What are all your specialties? Are you all internal medicine, HIV specialists, anesthesiologists?
HIV specialist.
Patients.
Oh, we have some clinicians, some non-clinicians.
We have some specialists.
Pharmacists, okay.
Internal medicine too.
Internal medicine, okay. No
No,
anesthesiologists.
doctors,
No
Dr. Joe.
surgeons. Okay, so then
Hospice.
I'm gonna take a really basic.
Yeah, all the MDs raise their hand.
I'm a junior physician, yes.
Okay, because I typically the audience that I give to is like UCSD, something like that, where.
I'm a professional patient.
These are very informed people in front of you, so go for it.
Okay,
It's okay.
so I usually talk to anesthesiologists and I say that. So this way, what it works is so I'll break it down like very simple. It's what we call the voltage gated sodium channels. And I know that sounds complicated, but in your body, you have sodium that has to come in and out for normal functioning. And that makes your body positive or negative. And in those cells, that controls whether you're gonna send a signal or you're just gonna not do anything. And so it's sitting right now, sodium, calcium, potassium coming in and out of your body to make your head look towards the screen, towards away, down to your phone, whatever it might be. So what you want to go and do is ideally you want to modify that from a pain standpoint. And so what we've identified is, and this is pretty well known, that sodium comes in and out of your body. That's why you eat salt and that's why you crave salt, right? I mean, because you need it to go and function, otherwise you're not gonna function. We call it hyponatremia and it's not a good thing to go and have, right? So there's multiple sodium channels in your body, in your head, in your heart, in your muscles, and then the ones that are responsible for pain transmission. So these are the three that you want to go and target if you're trying to reduce your pain from the periphery and like you hit something hard and what happens is you hit something hard, that muscle that signal gets sent to your brain immediately says remove your hand, right? Simple. We've all done that plenty of times. So the intricacy of all that is the sodium channels are opening up and sending this signal all the way up from your hand to your spinal cord, up to your brain. Brain comes back down, says, move your hand. So if you can stop that, great. You don't feel as much pain. So that's what you're really trying to target. You're trying to target these three. There are other medications out there. What they do is they target all of them, and so you get what we call toxicity. So you get these adverse events that are just not fun to go and have. And so you don't give them orally. I'm sure you've all heard of lidocaine somewhere along the way. Lidocaine, you give them an injection, a local injection, right? You keep it right there. You don't typically give it orally because if you give it to the whole body, you're gonna get all of these bad side effects. So what we try to do is only target these three, leave everybody else alone. And when we started, we said only these three. We realized that the 1.8 is the most, by far, responsible for pain transmission. So we said, how do we inhibit that? Sorry, go ahead. Did you have a question?
No.
Oh, okay. So this is what happens in a normal cell. And for the non-clinicians out here, people who are not neurologists, this is gonna look weird, so I'm gonna try to break it down. So you get a pain stimuli, you get hurt, you hit something. I hit this, right? What your body wants to do is let the sodium come into the cell. And then it can send that signal up to your brain. So if you can stop this from going up, you can stop that transmission from what we call the periphery, your hand, your leg, whatever. You can stop that from going up to your brain. That's what this does. It literally acts on that channel and says, nope, sodium, you want to come in? We're not going to let you in. So therefore, you get a less transmission of this pain. So the sodium is still trying to fight, saying, no, I feel pain. We're going to stop you right there. So this medication inhibits that. And the way that it inhibits it, is by literally just closing that channel. So this is really easy to see. The sodium ions are trying to come in. They're trying to say, hey, we feel some pain. We need to depolarize ourselves, which means get positive. And so this drug, basically what we call in medical terms allosterically, so it basically just causes it to close and say, you're not gonna get it. And so that inhibits that whole transmission from your hand, your leg, whatever, to your brain. So your brain has a lesser perception, sends a weaker response back to your hand saying, okay, this is pain, but it's not so bad. Am I making sense here?
If you stub your toe, is it making a difference?
What do you mean?
Do you feel it?
You feel the initial pain. So the initial pain is the other receptor, is the 1.7. So your initial response is 1.7. 1.7 kicks in, and that's a good thing to go and have because you don't want to put your hand on a fire and be like, cool, I'm good with this, right? Because your hand. So 1.7 is a good naturalistic response to go and have. So you move your hand, but then you don't want to feel all that pain secondarily of that fire, right? So you move your hand away, and then you're like, I'm gonna feel a lot of pain because I just got burned. That's where the have 1.8. So if you can just have the sensory reception of this is fire, move my hand, we're not touching that. We're touching the after fact of that, saying, okay, we're not gonna feel the pain of it. Now your hand's still gonna be burned, don't get me wrong, you're just not gonna be in pain. So you still have to bandage it up, you still have to do everything that you have because now you've got a burnt hand. Is that,
This might be
Yeah.
like a super basic question.
no, go for
But
it.
when we talk of sodium channel, I mean, when we think of this process of this signal going up and back down, we speak of nerves. So are these sodium channels nerves or is this another system?
They are what we call nociceptive neurons, so they're nerves.
Okay, so basically the sodium helps conduct the signal perhaps, or
That's essentially what the function is
Okay.
for the sodium to come in. Say, I'm a nerve, I need sodium to go and function properly.
Okay.
I'm gonna let it come in and send it up to the brain, and the brain does what it wants to do, shoots it back down saying, this is a lot of pain, I'm hurt. So if you can block that or mute that, then you feel less pain than you normally would. Go ahead.
So I broke 3 ribs 2 weeks ago.
Yep.
Progressively in more pain today. Would it still recognize the fact that pain level that I'm at now is not a normal pain? See what I'm saying?
Yeah.
It's not going in when you're at 0. It's coming in when it's seen 1.7 for 2 weeks, or whatever.
Yeah.
And will it work? Will it work then?
Yeah, so I mean, all of our studies, and I'll go over this, all of our studies are post-operatively.
Mhm.
So
Oh,
people
I
who have,
see. So, yeah.
they've gotten the abdominoplasty, they've gotten bunionectomy, they had to prove that they have pain.
Mhm.
So this is not people who are not suffering from pain.
Mhm.
Per the FDA, and a lot of people go and say to me, hey, Trog, we're gonna use this to prevent pain. So if you go into a surgery, you're gonna get pain.
Yeah.
So they're gonna use this to go prevent pain, but to your answer, we were required from the FDA to go and prove that you had pain. So imagine these poor people, they're getting this major procedure and they're not getting pain relief because they're in this trial. And so then they get this medication, but sure enough, it works on that.
And
Sorry.
unfortunately, most of the time with ribs, they don't operate and they just leave you just the way you are.
So we are doing a large study on rib fracture, it's a phase 4 study. So we are, because that is one of the common injuries that we have not studied,
Sure.
that the external community, mainly the physician community, wants to know what our efficacy is on that. But so I can't
It's a work in
completely answer it,
progress. Yeah.
but theoretically, we did studies in people who already had pain. So if you have pain right now, you can take it. Sorry, I know you have a question, but he was raising his hand first.
Okay, look, but I have neuropathy in my legs and feet. And then when it started, I was up all night crying, it was so bad, and they put me on massive things, including Mirage, and on an extremely large dose.
Yeah,
And then I said, because it's another medication, I just said, just stopped it. They said they came back, but after a while, I noticed that it got less, I thought. And then I switched to the Lyrica, and then I realized the pain was still there, I just got used to it. And I got on nothing, but after that, once again, I don't like taking all the time in, so I stopped that. And now, the pain is there, I know it's there, but only if I think about my feet, do I just feel the pain. And is that the brain controlling these things? Because
well,
it's there, I now know it's there, but it's not making me cry anymore all night long, even though I know it's there, and I have to be careful because I can get cut into that and not realize it, because it seems like it's a level of pain and the difference in the pain as opposed to the absolute pain itself.
well, first off, I apologize that you're having pain. Sorry that you have to go through this.
It's no problem, I mean, like I said, I personally don't take any medication for it because it's just a lot of medication to be taken, and, but I found out, I've actually gotten used to it. And all the time, it bothers me now, is when I actually think about my feet, then I can sit there and feel that there is pain there, but every day I don't think about it so much.
Yeah, so we are kind of studying the neuropathic pain that you're talking about, right? So the pain in your legs. And to answer your question, yes, it originates in your legs, but like I said, it can originate in your hand, and then it sends that message up to your brain. So yes, it is your brain. Like if you had some blocker right there on your legs, not sending that message up to your brain, one of two things would happen. One, I'd be worried about you because your periphery, your leg, is not talking to your brain. So that's a large problem. But you're gonna have that because the brain wants to perceive that as pain. So it doesn't know what's going on. It's a little confused. It's saying, hey, I've got some stimuli, something happened here. I don't know what it is. I'm creating pain. And pain is actually a protective factor. So they create pain, your brain creates pain to protect you from further injury. So it's like that whole fire thing, right? You can keep your hand there for 5 seconds or 5 minutes, but the pain makes you bring your hand. You keep it there for 5 minutes, you lost your hand now, right? I mean, like, so the pain is a protective mechanism that the body uses to go and do this. So I will show you our neuropathic pain. And our idea is it's gonna work in acute pain and in neuropathic pain. Sorry, go ahead. I got 3 minutes? Oh, wow. Okay, flying through. So we already talked about bunionectomy, abdominoplasty, works. It was compared to hydrocodone acetaminophen. I do have to tell you that it worked versus placebo. Hydrocodone acetaminophen, Norco, as Dr. Caperna asked, it was comparable. We did not beat it, but it was equivalent, essentially. So let me just fly through this because it works in abdominoplasty and bunionectomy, post-op pain. The AEs are actually very benign. So you're not gonna have a lot of nausea. With opioids, you get a lot of nausea. This doesn't have it, which is great. And then let's just talk about diabetic peripheral neuropathy. So this is it. So this is what you were kind of studying. So we studied it in DPN, diabetic peripheral neuropathy, as well as lumbosacral radiculopathy. The result, and you brought up gabapentin, but gabapentin is very similar to Lyrica, pregabalin, almost the same thing. And so we actually did a head-to-head study with pregabalin. You can see here the pain reduction was 2.09, with taking it 3 times a day. All of our arms were better than pregabalin. So right now we are in phase 3 with the 70 milligram dose. So obviously the one that reduced the most, 2.26. We're gonna have a placebo arm. We do have a placebo arm, and another lyrical arm at 100 milligrams QD. So the promise is that we're studying it. If everything goes right, we'll present our results by the end of this year. And then go through the regulatory filing, maybe in 2027, we will have an indication for neuropathic pain. So that's probably the most and then the last thing I'll probably bring up is we are committed to this space. So we have multiple molecules on deck. And so I would tell everybody, once we presented our results, all these other companies got funding. All these other companies started saying, okay, well, we got something on the shelf too. Now we're gonna study that. So the way I look at this is, yes, did Suzetrigine come first? Of course it did. But in 15 years, this is gonna be your NSAID. This is gonna be, do I choose ibuprofen or naproxen? Because there's so many companies, now that this target has been validated, there's so many companies that are going out there in 15 years. I firmly believe you're gonna have 10 options based on adverse events and efficacy. And then in 20 years, it's probably gonna be over the counter. Because the safety profiles are so good that it's gonna be like, hey, you know, honey, go to the pharmacy and buy me some Suzetrigine or the following medication. That's what's gonna happen.
You think it's gonna turn into like a 7-minute one or gonna go?
Oh, for sure.
Yeah, that's pretty interesting.
I think in 20 years, I mean, it's, the FDA usually requires a good 15-20 years of safety data. But the safety profiles on all of these medications are so clean. No GI bleed even, no liver toxicity, and has that. The NSAIDs have GI bleeds. You don't even have that in these categories. And so I think in 20 years, you're gonna go to the pharmacy, get it over the counter, and you're gonna have 1 of 10 options.
Any more questions? So, you guys say hang around for John real fast. He has his journey. Let's give him some time. You know, he just recently been hurt. What did that do?
He fell down, went boom, broke
Yeah.
two ribs.
We.
You wanna sit or you're okay?
We're way over time. We want to get.
Why is it here? Yes, I'm
There is no difference.
please.
Just moving back so you can run Zoom.
Okay, yeah. We're trying to get you on Zoom.
Okay, my name is John Spaniels. I have been deeply involved in all facets of HIV from the very beginning of my diagnosis, which was 30 years ago. No, 34 years. 34 years. May of 1990. And I have tried many different drugs along the way, and because I have been HIV positive for so long, I have tried many study drugs. You know, many of the drugs that are now just stuff you go in and they prescribe were drugs that were at the HNRC. It was called HNRC back then. So one of those drugs that I tried was Crixaben, and Crixaben is a protease inhibitor, and it is one that, as time went on, and this is the problem when you take drugs that are in the studies. They may show great up on a graph and whatnot, but when you put them in people, there may be some side effects that you didn't count on. One of them was that 3 to 5% of the people get they get diabetes from come down to diabetes from trying that. I mean, I also along the way got pancreatitis. Now, pancreatitis is the toxicity of the pancreas. Not being able to handle metabolizing and converting these things into enzymes and being able to have you get the positive effects of these drugs. So I ended up in the hospital for well over a month and probably was this far away from dying. I've been this far away several times. I got down to 15 T cells at one point. Dr. Pretty was the doctor too. And, so I went on disability like many of us did, and, I was also in a terrible car accident that resulted in 8 back surgeries, 2 ankle surgeries, et cetera, et cetera. So that's why my nickname is like Karachi. You know, because they live through everything. Now it's just, like I said 2 weeks ago, I fell down the stairs and fell on the doggy door and had this number on 3 ribs. But I just keep going, you know, the thing is that, you know, I never give up, you know.
Yes.
And, I try to stay as positively informed as I can. And this is why we do this, you know, this is exactly why Dr. Caperna said, let's do this and constantly try to stay ahead of the curve. And so these meetings are that, you're basically part of this group that has lived more years now than any other person that has HIV, you know, that came down with HIV, because the ones that were this age before died, they're all gone. So it's our job to be, I was gonna say Christopher Columbus, you know, but it's our job to really set the course and know about these things, because how many of you know about diabetes before you came in here? Do you even know the meaning of diabetes, you know? You've heard of it and whatnot, but did you know that you can ask your doctor to give you an A1C test, okay? And that's, as you heard, was a 3-month, you know, it basically checks your glucose levels in 3 months of blood. And therefore, it'll tell you right off the bat if you have it or you don't. You know, if you have other things going on to where you're getting heavier, fatter, like they talked about before, your eyes becoming a little bit, you know, you can't see that well and it happens pretty quickly. Anything like that, you know, I mean, one thing I think that's positive about being HIV positive is that it turns us into super hypochondriacs, okay? I mean, you know, if anything, say, oh God, what is this? You know, we're having a check. Whereas normies, you know, they basically go to the, especially men, you know, men, just put Windex on it, you know? So truly, yeah, you know,
If it's broke.
you have something, and another thing is, you know, questions are coming from him and back to his doctor, whether his doctor's telling him the right information or not. Nobody knows our bodies better than we know our bodies, okay? I mean, I'm gonna give you just a little outside example of this. I mean, I just had my went to a dermatologist and had my you know, whole body checked for skin cancer. Because this is a whole new nose. If you guys don't know this is a whole new nose that I got because of me taking control and Dr. Caperna again. I had a doctor, nameless, who said, I said, you know, doctor, the thing is that this thing keeps scabbing and bleeding, and I don't know. He said, John, you have to accept that you have like 80-year-old skin because of all the sun damage you've had. So we're doing the best we can here, and you just gotta go with it, okay? And I told Dr. Caperna that, and he said, no, we don't have to accept that. You don't have to accept that. Let's find somebody else. And I went to Dr. Michelle Pelly, who checked me, and she said, you mind if I do my own biopsies? I said, no. Encourage you. I don't know what's going on, but I know it's something. And she did, and there it was, skin cancer. Boom,
Wow.
boom. And as a result, I had to be operated on 3 times, you know. And today, unfortunately, it's back. Okay, but this is the first time in like 8 or 9 years, and partially it is my own fault because I saw a dermatologist once telling all his residents and students whatnot. He says, "You put you put it on like it's just lotion. You put sunscreen on from top to bottom every day. And, I don't do that anymore. I got lazy, you know, and I just wear a baseball cap, which leaves your ears exposed. I have a big old thing cut out from there, but in general, I look pretty normal, you know, and so it's important to take control of you, basically what I'm saying. I will go back, I went to the same doctor, said basically gonna fix my nose again, I spoke, you know, because I have seen some people's nose that didn't go to the plastic surgeon, and it was scary, you know, just terrible how it looks to have been able to cut that out. And we have to get it early, In the diabetes section, I can tell you this, I'm speaking, I'm talking, but am I walking the talk? Not so much, like he says. I am a sugarholic before I am any other kind of holic, okay? I mean, it is my, you know, put sugar, put cookies and milk in front of me, and I'm just like, go for it. You know, dessert. I wish I weren't, because, you know, it'd be nice to be able to, no. I do drink Coke Zero. As opposed to Pepsi. But I'll tell you something. It wouldn't hurt all of us to become, to go on a more heart healthy diet. Because what diabetes does is increases your chances of getting a heart attack or a stroke. And I don't know about you guys, but I have no desire to have a stroke, okay? Because that's a life that is no life for me. You know, so a heart healthy diet or the Mediterranean diet is really something that all of us can do. It's not too bad, you know, to have a salad and steak is pretty good. No, there's nothing wrong with that. Just get the dessert. So, that's all I'm gonna say to you guys today, because basically I'm encouraging you to know what diabetes is, to know that you can ask your doctor at any time to give you the test and ask, and it says why? Just say, because I just heard this huge presentation about it. I know that we are much more susceptible to getting that. The speaker is HIV positive and has it. And I'll tell you what, I'm worried much more about dying from diabetes than I am from HIV. So on the level of importance, it's exceeding, because I'm starting to get symptoms, and it started slow, and so I was a diabetic in denial, you know, and you know, whatever, desserts, whatever, you know, but the gadgets that we use are basically have gotten better and are increasingly getting better. This is what she was talking about in terms of the Libre and the Dexcom 7. This is the Dexcom 7, which happens to.
Oh, right here in the bag.
My phone. Okay. So instead of having to stick my finger 2-3 times a day, you put this thing on. You know, it has a little launcher too. I feel like it's just a lunar module. You know, just put it back and off it goes. And this tiny little needle that you don't even feel most of the time unless you get it. Goes in you, and then anytime that I want, there are my sugars, right there, anytime. And so if you start off right, which you're supposed to check them when you are fasting, you know, overnight. So you check these before breakfast, and you should be close to 100, you know, right around there, a little under 100. That tells you how careful to be. If you're over 100, you're 150 or 160, 170 or up, you've got a day of diet. Has to be, you know, you can't eat sugar today at all, because what happens is that then the medication, you have to give yourself insulin after you read this, and the insulin has to work so hard just to pull your sugars down that it just is that much more difficult. to beat something that's fighting against the current all the way for the day. So you check this all the time, 3 times a day if you want, and you know how you're doing. I'm not doing that great because it is over 150 consistently. And sometimes up to 300 or 400, okay? And those are levels that I should be running to the hospital on, and I haven't. But that's why I say I'm more worried about this than I'm worried about anything. And to you, I say, you know, you may not be worried about it, but the thing is that it may just come on quick. And it may just kill you before you even know it. Now, if you don't wanna worry about it, you say, I don't care, I just live the way I do. That's what my father said about smoking, and he's 64. So, thank you very much.
Thanks,
Appreciate it all.
guys.
Absolutely.
I know you're not a doctor, but I didn't know the first, I'm monitored by A1C, I'm not a doctor.
Yeah.
Well,
Yes.
but, is there any other way of finding out anything about that except for your, A1C and your fasting glucose? Is there any other tests?
Well, you can check your sugars with just a glucometer, okay?
I mean, just to see,
Yeah, just to see.
I want to ever suggest that.
And everybody.
I mean, it's a simple test, a little glucometer, you know?
Is that about the only things you can really, then you'll know more.
Well, yeah, and if you.
I'll go do that right now.
Weird things about you, think you're getting weird, or you're getting,
Yeah.
you're tired all the time, or you're
Yeah.
extra hungry. All those things together, okay, I'm worried, you know? But if you want to go to your doctor, say, I want to just check my sugar just for the fun, they'll do.
And you say it's supposed to be under 100?
If you're fasting, okay, if you just ate, it depends on what you ate, you don't want it to be above like 150, 160 regimen.
Okay.
But like John said, when you deal with your doctors, they will run a test on you, and they will ask you fast. They'll ask you to have a fasting, well, to do a fasting before you do the blood work in that morning. Always ask for morning blood work.
Yeah, right.
Yeah, I learned
I
that.
do that every 3 months.
That's the thing, you know, you're gonna do blood work anyway,
Yeah,
you can do it right there, no problem.
Okay.
Is there a home test that you can do your own A1C test?
I don't think so. I don't think so. No, I've never heard of one.
Okay,
I've read a lot.
on the back of your form, thank you, John, on the back of your form, there was a form that they asked if you had any ideas for the abstract. If you have any ideas, I think we have 2 of Jan's on here, but,
They could send it to us later, or
okay, thank you, Dr.
take a
Gilbert.
picture of it on your phone, your notes, and
Yeah,
email it to
you
us
can
or something.
reports. Okay, come on.
Call
Yeah.
Wanda, just talk to her.
Bug Wanda.
Call
They
Wanda.
appreciate
Call
it.
me.
Okay,
Call me.
someone donated, carriers, full carriers. So,
Everybody clap for that.
now,